Okay, so good morning, everyone. It's a pleasure to be here. I want to thank George and Janus for inviting me here to IPOKRaTES. I've drawn you a map here, or Googled it, from Europe, and no distance issues here because the Netherlands is situated right here, so really close by to Poland. There's the capital of Amsterdam, where my hospital is situated. George mentioned Amsterdam, Rotterdam. It's pretty much the same. Well, there are some people in the Netherlands that actually disagree with that. There's a big rivalry between Rotterdam and Amsterdam, especially in the soccer division. Some of the inhabitants of Rotterdam and Amsterdam will not speak the name. They will just use the area code of the telephone to address one or another. So just giving you some impression on the rivalry. If you've ever been to Amsterdam, you probably know it's a really great city. A lot of beautiful architecture. It's a multicultural city. A lot of people from Poland also living and working in Holland. It's a really fun place to be. I must remind you and warn you that if you go for a cup of coffee, the definition of coffee is not always the same as in your country, in the Netherlands, especially in Amsterdam. Unfortunately, our hospital is situated outside Amsterdam in much less impressive surroundings you can see here. And we are situated here in this tower on the 3rd floor, where we have a neonatal intensive care unit, depending on the number of nurses, with 20 to 24 ICU beds available. And in this unit, we tend to do some research on how to protect the lungs of our babies. And as you can see, we are in favor of using oscillation as a primary mode of ventilation. We're going to discuss with you that later on, the last day, when we talk about lung protective ventilation. So just to disclose to you that I've received research grants from Chiesi Pharmaceuticals and CareFusion. And today I'm going to talk to you about the delivery room. Peter already set the stage this morning, talking about how we should monitor our baby. And I'm going to focus on how we should titrate our interventions. How should we titrate pressure and oxygen use in the babies in these first minutes of life? So I'm just talking about the pulmonary transition immediately after birth. So not after that, should we use CPAP or intubate? This is a different topic. I'm going to take a fair amount of time talking about physiology, because I feel it's essential that you understand normal physiology before you can even start thinking about doing interventions in babies that do not do well. And I think it's important to realize that the human fetus is in a very different environment compared to exuterine life. So the condition of the lung is actually quite different. It's not involved in gas exchange as in normal exuterine life, because the gas exchange is governed by the placenta. And actually the lung is fluid-filled. There's no blood flowing through the lungs at all, but less than 20% of the cardiac output because of a very high pulmonary vascular resistance. And actually, the fetus is in relatively hypoxic environment compared to exuterine life, with saturations normally in utero somewhere between 50 and 60%. The primary focus actually is on lung development and not on gas exchange. And if we talk about lung development, we know that lung distension is an extremely important and essential part of normal lung development. And let's take a closer look on the factors that actually result in this lung distension. And the first factor is that the lung is fluid-filled, like I mentioned previously. And this is done by the alveolar epithelial cells that secrete, and it's a chloride-mediated secretion, fluid into the lung. And this fluid increase or secretion increases over time. These are studies done in lambs. And as you can see, this gestational age on the x-axis and the secretion rate on the y-axis, it slowly increases as the lung grows over time, leveling off somewhere at term age. In addition to this fetal secretion and filling up the lung with fluids, there are fetal breathing movements, starting off very early on in normal development, with the diaphragm being one of the main muscles resulting in these movements. And these movements are important in maintaining lung distension. And finally, the upper airway plays a very critical role in maintaining most of this fluid inside the lung and getting the lung distended. And if you look at the contribution of each of these factors in lung distension, this is shown here again in lamb studies, where under normal circumstances, where you have fluid secretion, a good upper airway, and fetal breathing movements, you can set this lung distension at 100%, as indicated here in the black bar. And if you take away fetal breathing movements or fetal breathing movements and the upper airway, you will lose about 40% of your normal lung distension. Now, interestingly, if you look at the lung distension compared to postnatal FRC, the lungs of a fetus are actually quite highly distended compared to extrauterine life, almost twice. So it looks like that the fetus is actually quite used to getting lung distension. So what happens around birth is this very complex thing that you go from a fluid-filled lung focused on development to an air-filled lung focused on gas exchange. So let's take a closer look on what needs to happen to make this transition a success. First of all, we need to get normal ventilation, which means that the fluid that's inside the lung needs to be cleared and needs to be replaced by air, getting a normal functional residual capacity at the end of passive expiration. And of course, we need spontaneous breathing. And in addition to this, we need to get normal lung perfusion, because as I told you, in utero, there's less than 20% of the cardiac output actually flowing through the lung. This means that there needs to be a rapid reduction in the pulmonary vascular resistance, allowing a normal cardiac output to perfuse the lung and taking up the oxygen. So how does this normally happen? Just let's start off with normal physiology. What happens with a term baby spontaneously delivered in this pulmonary transition? Well, first of all, the focus should be on clearing the fluid from the lung and getting the air in. And actually, this process of clearing fluid from the lung starts at the time of labor. And this is because the epithelial cells that used to secrete fluid in utero also make a sort of a transition from a secreting cell to an absorbing cell. And this is mediated by epithelial sodium channels, these ENaC channels. So these ENaC channels are activated at the time of labor, and they are starting to absorb the fluids inside the lung. And if you knock out these ENaC channels in mice, they don't do that well. If you look at the wild type with functioning ENaC channels and the knockout with non-functioning ENaC channels, you can see a big difference in the wet-dry ratio of the lung. Normally, with the wild type, the wet-dry ratio is reduced as the lung absorbs the fluid, but it is not the case in those mice that do not have the ENaC channels active. And if you look at survival, most of these mice that do not have the ENaC channels activated die within the first 48 hours of life. So these ENaC channels are very important, a part of normal transition and clearing the fluid from the lung. They are stimulated mainly by epinephrine. As you can see here, there's a reduction in lung fluid if you stimulate these preterm lambs with epinephrine, or beta agonists will also do the trick. And it's probably an interaction between more hormones like thyroid hormone and hydrocortisone, all playing a role in this mechanism of transitioning this epithelial cell from a secreting cell to an absorbing cell. In addition to this onset of fluid absorption at cell level, we also have some fluid loss by mechanical thoracic squeeze. When the mother comes into labor, there are uterine contractions, and at one point in time, the baby delivers through the birth channel, and this will oppose high forces on the chest, squeezing out some of the fluids that are still inside the lung before birth. And these are actually quite high pressures, up to 200 centimeters of water. However, at the time of birth, most of the fluid is still inside the lung, and the rest of the fluid needs to be cleared by the first postnatal breaths. So let's take a closer look at these first breaths. And these are really cool studies that were done in the late 80s by Weiss and Milner. I don't think you would get ethical approval for these studies nowadays. So what they did is that they went to the mothers in the delivery room, and as soon as the head was born, they inserted a fetal balloon in the babies and put a mask on the babies measuring the flow and volume. And then at that point in time, when everything was inserted, then they went on with delivering the baby, making it possible to measure the actual intrathoracic pressures and the flow and volumes that would take place during the first and the second and the third breath and so on. So what you see here is the first breath in a term baby at delivery. Here you can see the pressure, and here you can see the volume. So the baby begins with an inspiration. This is spontaneous inspiration, so we have a negative intrathoracic pressure. What you can see that immediately as the pressure turns negative, there's an influx of volume, which means there is no critical opening pressure before volume enters the lung. This is actually instantly volume enters the lung. You can see that the negative pressures produced by the baby are actually quite high. -50 is a mean, but sometimes going up to -100 centimeters of water. Just to give you some impression on comparing this what we are doing with the babies when we give positive pressure. And at the end of the inspiration, they usually have about tidal volume about 10 mL per kilo in. And then something strange starts. Then there's a massive increase of positive pressure during expiration, also going up to 70 centimeters of water in many of these babies. And at the end of this forced expiration, they end up with volume remaining in the lung, which is the first step of building up an FRC. And after this first breath, it usually is around 5 mL per kilo. It takes about another breath, starts up here, again going up, and slowly this baby builds up his FRC during these first breaths. So this means that the breathing pattern of the first breath in these babies is quite different than normal breathing. And Arjen de Pas, during his visit to Melbourne, looked at this in babies, looking at term babies and monitoring the flows and the volumes in these babies during the first 90 minutes after birth. Now, this is a tracing from a normal breathing where you see in green the flow going up during inspiration, reaching 0. Very shortly after that, you see the expiratory flow, a short pause, and then the next breath starts. And here you can see the change in tidal volume. So what happens in these babies when they are born at term and during the first breath? Well, there are many different patterns, but they all have something in common, which is that the baby breathes in, but then releases a little bit of air, but then keeps the air inside the lungs. And this is quite similar to what I showed you from these early studies from Weiss and Milder. The baby holds his breath, keeps the volume in there, and then at the end of a very long expiration hold, rapidly exhales and immediately inhales again holding the breath. So this is an expiration hold. You can also have crying, where you have a slow release of the inspired tidal volume over time. You can see these vibrations of the baby crying. Or grunting, again, slowly releasing over time during expiration the tidal volume that's been inspired. So expiratory breaking, postponing expiration as much as possible. And if you look at all these babies that were included in this cohort, and you look at the number of breaths, you can see that almost 9% of the breaths in these term babies in the first seconds of life are actually breaths with some form of expiratory breaking. There's almost no normal breathing in these babies. And the reason why they probably have a sort of an expiratory breaking is to push the fluids, which have a high viscosity, downwards distally, so it can be taken up by the interstitium and by the vascular space. It's also necessary to counteract the elastic recoil forces of the lung and to counteract the increased surface tension that is now created by the fact that you are no longer a fluid-filled lung, but now getting an air-filled lung. And at the air-liquid interface, the surface tension is much higher than in a liquid-filled lung. And to help the baby with this increased surface tension, we know there's a substance called surfactant that actually facilitates the baby in reducing this surface tension in making this normal pulmonary transition. And surfactant is secreted in human fetuses from about 28 weeks going upwards until the time of term birth. So at the moment that the baby is born at term, the surfactant production is at full rate, which means that it facilitates the baby in making this transition. In addition to this, if you stretch the lung during this first big breath the baby takes, by stretching cells, epithelial type 2 cells, you actually get a sort of a secretion of some surfactant that is still stored inside the cells, but is secreted into the alveolar space. Again, assisting the baby, lowering down the surface tension, and assisting the baby in making a normal pulmonary transition. So if we aerate the lung, building up an FRC, we also need lung perfusion to make sure that we actually get normal gas exchange. And this is already relatively old data from several studies showing that if you look at the pulmonary pressure as a surrogate of pulmonary vascular resistance, you can see there's a rapid drop in pulmonary vascular resistance over time in the first hours after life, making or governing normal lung perfusion and making gas exchange a success. The reason why pulmonary vascular resistance is reduced is still needs to be unraveled, but there are several suggestions, like by expanding the lung, you get a sort of an unkinking of the pulmonary vessels. Some say that the improved oxygenation will result in release of NO, and there are some stretch-induced releases of prostaglandins, which may result in a reduction in the pulmonary vascular resistance. So Peter showed us this data this morning, giving you sort of the normal reference values of unassisted birth at term, showing us that it takes some time, roughly about 4 minutes, to reach a saturation of about 90% in term unassisted babies. And if you think about the complexity of what I just showed you of pulmonary transition, it's actually quite logical that it takes time to make this transition from a placental-governed gas exchange to a gas exchange governed by the newborn lung. So to summarize this normal physiology, fluid clearance is a perinatal process starting before birth, and the ENaC channels I showed you are very important in this mechanism. There's expiratory braking in almost all breaths, and there's surfactant release, and both these two are important in creating a normal FRC. And it takes several minutes before you get normal or adequate oxygenation. And I think the key message is that in case of uncomplicated delivery at term, the pulmonary transition is a spontaneous, unassisted event. So as Peter showed us this morning, looking at a baby, taking your hands off it, the baby will transition by itself. Allow him to transition within the first 4 to 5 minutes after birth. So does it matter if you're born by the vaginal route or by cesarean section? There are some indications that permanent transition is somewhat delayed if you are born by cesarean section. These are studies done looking at the number of babies that actually need oxygen in the delivery room or some assistance, and especially if you have an elective cesarean section, so without labor, these babies probably have a longer transition. And there are several reasons why babies born by C-section at term actually have a compromised pulmonary transition. First of all, they're probably less efficient in fluid clearance because the ENaC channels are often not activated by the epinephrine surge that normally starts with labor. And there are some data out there where they measured the ENaC activity in epithelial nasal cells, which are sort of reflecting what's happening deeper down in the lung, showing that if you look at this ENaC activation, especially in babies that are born by a C-section without labor, that this is increased. Potential difference indicates that there is less activity of these ENaC channels in these babies born by C-section. there seems to be a less efficient mechanical fluid clearance and formation of FRC in these babies. Again, studies done by Weiss and Milner, where they compared in these first breaths the pressures either when the babies are born by elective C-section or vaginally. And what they could show that the delivery pressures, so these pressures that are posed on the chest of these babies and squeeze out some of the fluid, are actually half in those babies that were delivered by elective C-section compared to vaginal routes. And what you also could see is that there's expiratory braking, and the pressures that baby makes during expiratory braking are lower after C-section compared to vaginal route, and resulting in the end in a less buildup of FRC in those babies who are born by elective C-section compared to the vaginal route. And this probably takes several hours before these babies catch up with their term babies that were born via the vaginal route. And this also is reflected if you look at the normal SpO2 levels in unassisted birth and unassisted transition. You can see that during these first 5 minutes, the babies born by C-section lag behind a little bit of the babies who were born by vaginal delivery. So to summarize, yes, there is a difference probably for term babies born by C-section compared to vaginal delivery. There seems to be some compromised fluid clearance and building up of FRC by the factors I mentioned here below. And it takes several hours before these babies fully catch up with their vaginal delivered peers. However, in the end, the same is true for these babies also, that most of these babies do not need any assistance for their pulmonary transition. So let's take a closer look at the asphyxiated newborn baby, a term baby. Now, this is probably quite different than from the spontaneous delivery in a non-asphyxiated term baby. We get into trouble because these babies do not have or insufficient respiratory drive at the time of birth. And we just showed you that we need these postnatal breaths as one of the important factors to clear the fluid from the lung and to build up this FRC. In this case, clinicians clearly need to assist these babies in the pulmonary transition. And the first priority should be that we should establish a normal FRC and ventilation as soon as possible. So again, studies done by the Milner group in the early 80s. What they did now, same procedure, baby's head was born, a cervical balloon inside, measuring the pressures and measuring the flow. And because these babies were not breathing on their own, they needed assistant ventilation, so they applied a peak pressure of 30 centimeters of water in a frequency of 30 to 40 per minute, and they used an inspiration time of 1 second. You can see now again the pressure and the tidal volume they measured. And what you can see now, the pressure of course is positive because we are applying positive pressure to these babies. Now you can clearly see that in most of these babies there's sort of a critical opening pressure. So you need to achieve a certain pressure before you can actually get air into the lung, which is quite different from what I showed you with the spontaneous breathing babies. And in most of these babies, this critical opening pressure was about 20 centimeters of water. If you look at the tidal volume that is reached when you use these settings, it's about half of what babies reach during their first breath during spontaneous breathing. And the same is true for the FRC. So it seems to be a less efficient way of clearing lung fluid and building up normal FRC and ventilation. What they also could show is that most of these babies that you start positively ventilating get sort of a reflex, and there are two possible reflexes. There's a rejection response, sort of an expiratory effort of the baby, resulting in a positive esophageal pressure. And there's the head's paradoxal reflex, which means that following a positive pressure breath, the baby has an inspiratory effort, resulting in a negative esophageal pressure. However, what they showed in these experiments was that the best and the quickest way to get the fluid out and build up the normal FRC was once the baby started to breathe on their own. Now, the interesting thing is what they showed in these first experiments when they did a positive breath. At the end of the 1 second inspiration time, there was still air entering the lung. And this triggered Weiss and Milner in maybe we should prolong the inspiration time, allowing more air to go in. And this is, I guess, the first step to what we now call a sustained inflation, so prolonging the inspiratory time of a positive breath. So they repeated these experiments again using a peak pressure of 30, but now they increased the inspiration time from 1 second to 3 to 5 seconds. And what they could show is that there was still sort of an opening pressure, but it tended to be lower compared to the 1 second inspiration time. And by extending the inspiration time to 3 to 5 seconds, they now were able to get a normal comparable tidal volume and a normal first FRC buildup comparable to the spontaneous breathing infants. And I guess this is the basis for the sustained inflation that's so hot in delivery rooms nowadays. It's in these papers in the 1980s. Okay, so in addition to getting these asphyxiated babies up and running on ventilation and FRC buildup, we know now from, and this is, I guess, we all agree on this, that we should resuscitate these babies with room air. There have been several studies showing that if you use 100% of oxygen, you will get an increase in mortality in the asphyxiated baby. So this is no longer a big issue. I guess everybody here in the audience uses room air when resuscitating term babies, right? Okay. So summarizing this bit on the asphyxiated term baby, most of these babies require an opening pressure, usually above 20 centimeters of water. And if you remember the high pressures that these babies build up themselves, it sometimes goes up to 25, 30, or 35 centimeters of water to get this lung open in these babies. A sustained inflation up to 5 seconds seems to lower these opening pressures and improves the buildup of a normal FRC and a normal tidal volume. However, we don't have any randomized controlled trials that ever looked at sustained inflation in these term babies, although it makes physiological sense to apply them. And of course, as we already mentioned, we should start with room air when resuscitating these babies. So the final group I'm going to discuss is the preterm infant. Again, there are several compromising factors when we talk about the pulmonary transition and preterm infants. First of all, preterm infants also have a reduced ENaC activity. So this transition from the epithelial cell going from secretion to absorption is less in preterm infants, again shown by measuring potential differences at the nasal epithelial cells, showing that compared to the term babies, especially the babies with RDS, have less ENaC activity at the time of birth. They're often surfactant deficient, which means that their surface tension is high at the air-liquid interface. They have a reduced muscle strength, meaning that they can't create these big inspiratory and expiratory pressures that you probably need. They have a more compliant chest wall, which makes breathing very ineffective in these babies, which means that all these factors will probably compromise the baby in having a normal pulmonary transition, clearing fluid from the lung and building up the normal FRC. However, we nowadays tend to treat the mothers with prenatal steroids, and these prenatal steroids have some good effects on these compromising factors. It upregulates the ENaC activity, and prenatal steroids increase the biochemical and structural maturation of the lung in these preterm infants, which actually has resulted in that many of our preterm babies do manage to have a pulmonary transition, sometimes unassisted. However, it is compromised, and if you look at the normal reference values for SpO2, preductal SpO2 in our babies, you can see it takes about 2 to 3 minutes more time for a preterm baby unassisted to reach a normal saturation of 90%. One of the key questions is, do preterm infants need a sustained inflation? and or PEEP or CPAP, depending on how you apply it, during pulmonary transition. I think it's important to acknowledge that the preterm baby isn't that different from the term baby when it comes to its breathing pattern. Ian Tapas also measured these breathing patterns in these preterm babies in the first 90 seconds of life. And as you can see, also the preterm baby has expiratory braking, almost identical to the term baby. So this preterm baby actually is quite capable of using his own mechanisms in building up an FRC and clearing the lung from fluid. There's actually, if you look at the effect of PEEP during the first minutes of transition, there's only one trial that actually looked at this. And this is a trial done by Neil Feiner, where they randomized 100 babies with a mean gestational age of 25 weeks to resuscitation with a face mask and TPs with CPAP, PEEP, or no CPAP, PEEP during transition. So these babies could be ventilated, but they were ventilated with or without PEEP. They found there was no difference in the need to intubate these babies in the delivery room. It was about 50% in both groups. And they didn't report any other differences, although they didn't look at the long-term outcomes. And they concluded there was no clear benefit of applying CPAP or PEEP in these babies within the first minutes of life. So how do we synthesize this? Do we need PEEP in our babies? I guess if you look at the physiology, I think we should apply PEEP to all babies at least below 32 weeks gestational age. And the reason for this is that they are, as an individual, prone for low and expiratory lung volumes. These babies are, like I said, surfactant deficient. The chest compliance is extremely high, so these babies tend to have a low lung volume. So I would say the physiology allows for applying PEEP during transition. And again, we already know that the benefits of CPAP and PEEP after the first minutes of life has been well established. So I guess my take on this is that we should apply PEEP in these babies. We should certainly apply PEEP in all babies that we intubate and start ventilation, because by bypassing the upper airway with an endotracheal tube, you are taking away the normal mechanisms of this baby to build up expiratory pressure. And this is nicely shown in these videos from, again, the Melbourne group, showing rabbit lungs at the time of pulmonary transition that were endotracheally ventilated. And I'm going to show you a video here where we start ventilating. Maybe the lights should be dimmed a little bit. It shows you what happens during ventilation. You can see the airways coming up there, and you can see that slowly the lung gets aerated. But at the end of each expiration, you can see that you lose all the lung volume in these babies. And this is also shown here, where you get, at the end, normal tidal volumes, but you're not building up any FRC in these rabbits because you are not applying any PEEP in addition to positive pressure ventilation. If you do the same, but now apply PEEP, you can see there's, again, slowly recruiting the lung volumes, clearing the fluids, and establishing an air-filled lung. And now you can see that at the end of each expiration, you will maintain aeration of the lung with a normal FRC. So it's important that, independent of gestational age, at the time you intubate a baby in the delivery room, you apply PEEP. What's the optimal PEEP or CPAP? We don't know. Actually, there are no studies out there that actually compare these different levels of PEEP. Probably is, for me at least 5 centimeters of water, or maybe even higher. So what about a sustained inflation? We talked about a sustained inflation in the term asphyxiated babies. We know that there's a physiological rationale for these babies to give a sustained inflation because they're not spontaneously breathing and they're not building up their own FRC. There are actually 3 studies that looked at sustained inflation in preterm infants. And they're quite different and they're quite complex to tease out what the actual effect is of a sustained inflation. The first study was done by Harling, and this study included only patients that were apneic or had an insufficient drive. They were 28 weeks mean gestational age, and they compared a sustained inflation 2 seconds versus 5 seconds, using a peak between 25 and 30, a PEEP of 3 to 4. They used a T-piece device, and they used a mask or an endotracheal tube. And they couldn't find any difference in the outcomes that were measured in these babies. The second trial was by Lindner. They included, just like the PAS trial, not just babies who were apneic, but also babies who were having severe respiratory distress, so tachypneic retractions. They were also included in these trials. So Lindner, slightly younger babies, 27 weeks, they compared no sustained inflation to a sustained inflation of 15 seconds, 20 to 30 centimeters of water, 4 to 6 centimeter water PEEP. They used a mechanical ventilator as a device and a nasopharyngeal tube as the interface, again, showing no differences between the two groups in the outcomes. And the largest study is done by Arrington Puss from Leiden, and this is a complex study. So I'm going to take you through it. Actually, there were more differences in the two groups than just sustained inflation. There were slightly older babies, 29 weeks. The intervention group received a sustained inflation of 10 seconds compared to no sustained inflation in the control group. However, the intervention group also received PEEP, 5 to 6 centimeters of water, and the control group did not receive PEEP. The intervention group with sustained inflation were resuscitated with a T-piece compared to a self-inflating bag in the control group. And the intervention group received a nasopharyngeal tube compared to the mask in the control group. So at all of these different aspects, there are differences between the two groups. In the end, the package of a sustained inflation with PEEP, a T-piece, an MPT, resulted in the babies with sustained inflation to have a less need for mechanical ventilation within the first 72 hours after birth, and less babies having BPD at 36 weeks. So there seems to be a signal out there that intervening in these first minutes of life may have an impact on longer-term outcomes. However, it's impossible to tease out if it's sustained inflation or PEEP versus no PEEP or T-piece versus self-inflating bag, or if it's the combination of all of these aspects that actually gives you the benefit on the long-term outcome. So again, what's my take on this, on recommending the use of sustained inflation? In our unit, we only use sustained inflation in preterm infants with no or insufficient respiratory drive. So the baby is not breathing or breathing below 10 times a minute. If possible, I would say allow for spontaneous breathing of the lung and support it by CPAP or PEEP. So letting the baby itself clear the lung fluid, build up the FRC, let him use his own mechanisms and not intervening in this normal transition. Again, we don't know what is the optimal sustained inflation. If you ask me how much pressure, 20, 25, 30, we don't know. We don't know the time that's needed in these babies, 5 seconds, 10 seconds. Should we individualize? Because we are moving to a sort of one-size-fits-all protocol. All babies get a sustained inflation of 20 or 25 for 10 seconds. While maybe we should individualize. This baby needs 20, this baby needs 25, this baby needs no sustained inflation. And we don't know if it's volume we should use or pressure, and how should we monitor response. So there's a lot of issues out there on the sustained inflation, and I'm just being cautious that we should not apply sustained inflation to all of our preterm infants because of mainly animal research. Because we know, like Peter told us this morning, too much pressure and volume can be injurious to the lung. We just need 5 or 6 of these overdistensions to get into trouble. If you look at the ILCOR guideline, it's pretty vague on sustained inflation and PEEP. There's no firm recommendations, and they also mentioned the apneic preterm baby might benefit from a sustained inflation using either short or longer TIs, whatever that means, and that PEEP is likely to be beneficial. So there's still a lot of unanswered questions on how to support these babies at birth. Do they all need supplemental oxygen? It's another important question. We are at least struggling with our unit. We know the data on the term babies, that room air is superior to 100% of oxygen, but this is also true for preterm babies. We don't know. The data out there are actually quite limited. There are only a small number of randomized controlled trials that compare a higher versus a lower FiO2 at the time of resuscitation. Overall, if you look at some of these results, there seems to be a reduction in mortality favoring the lower FiO2. But if you look at the recent meta-analysis that has been published in PLOS ONE, it seems to be, yes, there is an overall effect on mortality, but if you tease out the trials in the different subgroups and you look at trials where the allocation was concealed, compared to those trials where allocation was not concealed, you can see there's a big difference. And if you look at these more methodological robust trials with allocation concealment, there was no significant difference in mortality between the lower and the higher FiO2 that we use. So we're not sure what is the appropriate FiO2 in these babies. There are no major differences in most of these trials and other outcomes. And the funny thing is that most preterm infants do need oxygen. Also, those trials starting off with extremely low FiO2s, most of these babies need an increase in FiO2 during their normal transition. So again, making some recommendations for clinical practice, it's difficult to make these firm recommendations. It's just a way of synthesizing the data and looking at the physiology. The primary focus should always be establish FRC and establish normal ventilation before increasing FiO2. Aim for improving heart rate, muscle tone, and spontaneous breathing. Monitor, we've learned this morning that we are not very good in judging saturation by the color of the baby. And I guess what we do is you start either higher or lower, but the main message is you have to take a dynamic approach. Monitor saturations and titrate your FiO2 as soon as possible using the reference values that are out there now, telling us what the normal unassisted SpO2 change would be over time in preterm infants. And just to give you an example on this, this is a study done by Max Vento, a study where they used a lower versus a higher oxygenation group. The lower group started at an initial FiO2 of 30%, the higher group at 90%. And as you can see, in the lower group, they needed to increase the FiO2 to about 5 minutes, ending up somewhere around 50%. And in the high group, they were able to reduce the FiO2 to about 50% with no difference in the groups after this point in time. And if you look at the change in the SpO2 in these two groups, you can see there's not a big difference. So the key thing probably is to be dynamic, starting off with some FiO2, but monitor and try to titrate down as soon as possible if you're using higher levels, or slowly going up when using lower levels of FiO2. So to summarize this on the preterm infants, they are at an increased risk of a compromised pulmonary transition. Although there is a rationale for using sustained inflation and PEEP, the optimal settings and the long-term effects are still unclear in this population. And most preterm infants do require some supplemental oxygen during transition, but the optimal targets and approaches are unknown. So wrapping up with some overall conclusions is that most newborn babies do not require pressure or oxygen during pulmonary transition. And this is, I think, a very key message for all of you out there. And if the assistance is needed, I think we should titrate this as much as possible to the individual, avoiding too much and too little support in these babies. And I think it's essential to understand normal physiology and pathophysiology before intervening in this process and titrating these assistants. And we need a lot more research to determine the optimal support during pulmonary transition. Thank you very much. Any questions? All clear? All right. Lunch, I guess.